Thanks, Brian. It's great to be here with old friends. I just asked Alex what he was thinking when he assigned me this talk title, Bleb Wars. Probably should have asked, back when he invited me 6 months ago. But, this is really the home of tubes. And, Doheny and Jules Stein are now under the UCLA umbrella. But we all know they have a competitive history, and it even extends to tubes, as Jules Stein is best known for their work with the Ahmed glaucoma valve, and Joe Caprioli and Ann Coleman and Simon Law, in particular. And USC with George Barfelt has a long history of obviously using the Barfelt valve, and most of the early work was done there. So a lot of the clinical trials I'm going to show you are from one institution or another. I don't have any financial disclosures related to this particular talk. I'm going to focus really, as Brian said, on clinical trial evidence. I tend to be influenced a lot about my last disastrous case as well as the next person. But, we really should look at a lot of the clinical trial evidence to decide what to do. And that's, I think, where the Bleb wars start. It's this versus that and that versus this. And I've been involved in a few of these clinical trials. But I will show you some results from combination of trials in some pooled analysis work that we've done with ABC and AVB, and that now we're drawing in TVT patients. So here's some blebs, the blebs that we see with trabeculectomy, thin-walled, prone to leaks and infections, the circumscribed blebs of Ahmed valves, which can have very high blebs that can cause diplopia and whatnot, and then the Barfelt valve with its lower profile but more diffuse bleb, and which one's better? Well, there isn't one that's better, and that's, I think, the lesson of these trials is that we do need to individualize patient care, and we can use clinical trial data to do that. So this is a slide I borrowed from your own Paul Sidoti, who did his glaucoma fellowship here at Doheny and is now director of glaucoma at New York Eye and Ear, because the blebs that we get with trabeculectomies and aqueous implants are dramatically different. And it's like comparing apples to orange, even to have clinical trials against each other, but that's what we do. Trabeculectomy blebs are perilimbal, whereas aqueous shunts are equatorial blebs, much further back. Trabeculectomy blebs rely on transconjunctival flow, whereas aqueous shunts use passive diffusion through a generally thick capsule, and so on. We need antifibrotics to make our trabeculectomies work for the most part, and we're working now with the folks from UCSF to see if that helps in shunts. But just realize that these are drastically different operations from start to finish and for long-term follow-up. And I'd just like to take you through some lessons that I've learned compiling the clinical trial data on blebs, starting with clinical trials done here at Doheny by Dale Hoyer and many of your graduates and former faculty. First, that bigger is better, and Dale termed this study, which is better, 1 or 2, to compare a single plate Multino to double plate Multino, and did one of the early prospective randomized clinical trials in glaucoma here at Doheny, and found a higher success rate at 2 years with a double plate Multino with similar rates of vision loss and yet a higher rate of surgical complications. And we're going to see that kind of as a theme, which is, yes, bigger is better, but there may be an expense to pay. So just remember this early trial from the late 90s when we didn't have Ahmeds or Barfelts to study. But it doesn't mean that bigger gets you more. So the next trial that was done at Doheny looked at the 350 Barvelt and the now discontinued 500 Barvelt implant, and there really wasn't a difference going to the even larger size, and that's why the Barvelt 500 was actually discontinued. 350 seemed to be the upper limit of what was good. And so, interestingly, now we're wondering whether the 250 implant, which was marketed as a pediatric barbell, but many of us now use instead of the 350, perhaps shows equivalent pressure lowering. And so I've switched in my practice from 350s to 250 just in the past couple of years, as there's mounting evidence, that perhaps, 250 is the maximum. The second lesson that we're learning and is still evolving is the story of tubes versus trabs. And as primary surgery, it seems like they have similar outcomes. And this work was done by Roy Wilson, comparing the Ahmed S2 to trabeculectomy in Sri Lanka. And this is a randomized prospective trial that lasted for 31 months and really found no significant difference in mean IOP in this particular demographic group, and no difference in visual acuity or postoperative complications. A new lesson that has been added to by the group at UCLA recently that I've adopted in my practice just in the past year or two is that starting aqueous suppressants after tube implants can really decrease the magnitude and duration of the hypertensive phase. Early work out of Tehran using a randomized prospective trial did show that starting a fixed combination of timolol and dorzolamide twice a day, once the pressure got above 10, was better than what we all had been doing, which is stepwise therapy when the pressure got above our treatment goal, which could have been 18 or 21. And so there was definitely something beneficial about early aqueous suppressants applied to Blebs when the pressure even reached the double digits in terms of long-term success and minimizing the hypertensive phase. And then, in fact, Simon Law and the folks at Jules Stein did a study that confirmed this, randomizing patients to early treatment when they're above 10 or later treatment above 17. And although there was no difference long-term in that study, there was definitely a difference in the magnitude of pressure rise associated with the hypertensive phase, which is one of the things that really limits this surgery overall. To provide some lessons from the tube versus trab study, which we all know that trabeculectomy with mitomycin C and Baervat implants were able to produce sustained lowering of IOP into the low teens, which is something we had not seen before in the literature. The assumption was that a trabeculectomy with mitomycin C was your go-to operation to get pressures super low because implants left your pressures too high. But in fact, with enough medical therapy, you can get the pressures down with the Parfeld 350 implant. So this was the conventional reasoning. Again, a Sentinel article written by Don Minkler while he was at Doheny, basically saying that that aqueous shunts might be a poor choice for IOP control, but in fact, the mean IOP at 5 years, there was no significant difference between the two groups. And in fact, if you're looking for pressures less than 14 millimeters of mercury, both groups do relatively well. So that was sort of new data. But tube shunt surgery will require more medications to get there. So for your patients that perhaps are intolerant of medications or for whatever reason can't take them, perhaps trabeculectomy augmented with mitomycin or antifibrotics is a better choice for getting pressures very, very low. So that's how we can start to kind of individualize clinical trial results to the patient sitting in front of us rather than trying to just have one operation that fits all our glaucoma patients who need it. So just looking at the trabeculectomy versus tube study, at 5 years in refractory patients with previous trabeculectomy or cataract surgery, there was a higher failure rate in the trabeculectomy group out to 5 years compared to the Barbell 350 group. And so that has, shifted a large number of glaucoma specialists to use at least the Barfeld 350 as surgery once someone's had incisional surgery. And even if you look for lower pressures, let's say a target group of less than 17 or less than 14, the tube group has a lower failure rate. The reason for treatment failures in most of these trials is inadequate IOP, but notice persistent hypotony accounted for 31 of the failures in the trabeculectomy group. So that, just something to keep in mind. The next lesson from these trials were that there's just more reoperations needing to be done in patients who fail because of trabeculectomy. And that's pretty intuitive because more patients are just failing in general and needing more operations. And the next lesson is that vision loss is, relatively common in these patients with severe glaucoma who get tubes or trabs, but pretty much equal between the two groups. The next lesson we learned is that early postoperative complications occur more frequently after trabeculectomy with mitomycin C compared with tube shunt surgery, but late complications are similar in the two groups. And I would add that these early postoperative complications were generally self-limited and transient, meaning not a lot of interventions need to be done. But things like early wound leaks that eventually sealed were, just more common in the trabeculectomy group. And if you look at the early complication groups in TVT, was definitely higher in the trabeculectomy group, but late complications and serious complications were similar between the two groups. That brings us to the primary TVT study, which is now producing 3-year results, which will be presented at AGS in San Francisco. And after the success of tubes in the TVT study, the question arises, hearkening back to Roy Wilson's landmark study, should we be considering tube surgery as primary surgery in patients who need it with glaucoma? And in this study, the 350 Barvelt was compared with trabeculectomy 0.4 milligrams per milliliter for just 2 minutes instead of 4, which was the dosage and duration for the TVT study. And recruitment finished with 242 patients, and at 1 year of follow-up, which was published just in 2018, there were about 110 to 120 patients left in each group. Lesson 10 is that basically there was a greater IOP reduction with fewer glaucoma medications in use in the trabeculectomy group than the tube group after 1 year. So here's a sort of a reversal of results already. And, basically in your primary surgery patients, perhaps trabeculectomy is the best initial first surgery. That's why we need to do clinical trials. But you can see that throughout the first year, the trabeculectomy group had lower pressures, and even at 1 year, that was statistically significant. And in addition, there were fewer medications in use in the trabeculectomy group. So this is sort of the, IOP and medication results of the 1 year primary TVT study showing lower pressures on fewer medications in the trabeculectomy group. Success and failure shown here was also statistically significant, with just 8% failures in the trabeculectomy group versus 20% in the tube group. And again, we're going to see 3-year results presented at AGS in March. The reasons for treatment failure, of course, were inadequate IOP reduction for the most part, reoperation for glaucoma. We haven't seen a lot of late hypotony yet after just a year. But there were some interesting additional findings. Risk factors for failure included, of course, randomized treatment, but preoperative intraocular pressure. And the effect was not something anybody anticipated, but the failure rate was higher in the tube group in patients who started with lower baseline intraocular pressures. And we're going to see more about that shortly. And this is a very interesting result, which is if you stratify patients based on low starting IOPs, medium or high IOPs, look at the huge difference with the tube group failing 36.5% of the time in the subset of patients that started with low intraocular pressures initially. So again, we're starting to see clinical trial results that we can use to individualize patient care, such that in patients who are progressing in the upper teens or aren't at their target IOP, but don't have super high intraocular pressures, tubes may not be the best surgery. So, I think this is really valuable information for us. So the conclusions at 1 year are that trabeculectomy with mitomycin C had a higher success rate than tube shunt surgery, with greater IOP reduction on fewer medications, and patients with lower preoperative IOP had a particular benefit from primary trabeculectomy compared to primary tube shunt placement. And lastly, I'd like to present some results that we did by pooling the actual data from the ABC and AVB study, which were two similarly designed clinical trials to compare the Ahmed versus the Barvelt implant. And they were conducted pretty much simultaneously, run out of the Bascom Palmer Eye Institute and University of Toronto. And so both studies were to compare the safety and efficacy of the Ahmed FP7 to the Barvelt 350 implant. And the pooled analysis included 514 patients with similar entry criteria, which is why we're able to do that out to 5 years. And basically, the two studies were quite similar in terms of age and demographic characteristics, as well as glaucoma diagnoses. And this study found similar success rates with the Ahmed FP7 and the Barvelt 350. So these are the failure graphs for the pooled analysis. And there was a slight edge for the Barvelt implant when you're talking about trying to get lower intraocular pressures. And in fact, when you look at the intraocular pressures out to 5 years in these two studies, the intraocular pressures in the Barvelt groups was statistically significantly lower than the Ahmed group. So although the failure rate was the same, lower pressures were achieved with the larger plate implant, basically verifying what we saw with Dale Hoyer's early studies of the size of implants mattering. But and in addition, there were fewer glaucoma meds in use for the Barvelt group because we're able to get lower pressures on fewer medications. So again, in your patients who perhaps are, can't tolerate, 4 or 5 medications, just know that you have the potential of getting lower pressures with a Barvelt 350 implant than the Ahmed implant. Basically, the only real difference in the ABC AVB pooled analysis between the two groups was there were more serious complications with the Barvelt implant because, you might say, well, why don't we put a Barvelt 350 in everybody then if you're going to get lower pressures eventually? There's that cost to be paid that really Dale Hoyer uncovered early for the larger plate implant in terms of particularly hypotony-related serious complications. So just something else to keep in mind. So, just sort of bringing all these Bleb wars together, some things that we can learn are that, the Barvelt implant seems superior to trabeculectomy with mitomycin C in patients who have had prior incisional surgery. That's a lesson from the TVT. But in primary surgery, Trabs do better, at least at 1 year. So we'll see about 3 and 5 years. Basically, I've changed my practice since doing the ABC study, and I use Ahmed implants for patients with uncontrolled intraocular pressure with neovascular glaucoma who need rapid, consistent IOP lowering right away. But then if I need really lower long-term intraocular pressures, I'll use a Barvelt implant. And so when you need very low pressures, or if your ability to use glaucoma medications are limited, then perhaps the Barveld implant is the go-to implant of choice. And then lastly, this issue of hypotony, long-term following the larger plate implant, is of concern. So, certainly patients who might be at risk for hypotony maculopathy, I would consider starting with a smaller implant like the Ahmet. You can always go bigger later in a different quadrant, but that may be safer. So thanks again, Alex and colleagues, for inviting me. It's a real honor to be included today.